So most pathologists know it's a problem in the clinical laboratories that we are not visible. We are not visible as pathologists. We're not visible as technologists. That's why there's this big differential between nursing and technologists, which none of us have understood. Let me get this straight. You go to college, they go to college. They make more money than you make. How does that work, right? I've been around a lot of smart people and telling you, well, I don't know. Where are they? They're in this room with all these machines, right? So the pathologists, I think, have to lead the way here. And a lot of people say, well, you know, I'd love to be more consultative, deal with the patients and what they need and help the docs. But the trouble is that most people who do anatomic and clinical pathology don't really learn the clinical pathology. Why is that? Actually, there's a good and justifiable reason. And that is that if you're a pathologist, it was easier to get paid for doing anatomic pathology. So if you could get a job where you could guarantee yourself $200,000 for looking through a microscope, and every time you said malignant, you know, a $100 bill fell from the ceiling, then you'd figure this is what I want to do. I had a friend who's a cytopathologist tell me that she was the clotter for Michael DeBakey. Now, would that be a cool job or what, right? And she had to quit because she didn't make enough money. I mean, by helping them figure out blood products and coagulation defects and all this fancy heart surgery, she couldn't make a living. I thought that really told the story. So, unlike anatomic pathology, people are not sure they're going to get paid for it. That's a really good reason. And a lot of times, you look at what your expectation is. We have done nothing on it for so long that when I remember going to the MGH, and when we started being consultative, one of the diabetologists said, you know what? We never really thought you knew anything that could help us. Whoa, really? That whole big clinical laboratory with all those people, we didn't think that we could ask you a question and that you would actually be able to tell us. What an observation. And the other thing is that pathologists, and maybe all of us in the room, we tend to be a little bit more timid maybe. You know, it's like, oh. And this is a change too. And you know, no change happens without some bold champion saying, I'm going to do this because it's the right thing. And so this fear over the turf war, you know, what happens if I give advice in hematology? Is somebody in hematology going to come over and say, what are you doing and what do you know, right? So there is a little bit of that that you might experience in this development, always looking at the benefits of the patient. Now, in the mid-90s, it was decided, the government decided that maybe they would pay for a professional interpretation of some lab tests. And most of these are microscopics or looking at gels or gram stains, but it wasn't enough to take the average pathologist in a community hospital and say, I'm going to embrace clinical path. I'm going to learn it. I'm going to be consultative. So here's what happened in the mid-90s. They made these codes, and they put a 26 after them. And if you take away the 26, that's what they pay for doing the test. But if you put the 26 on, that's what they pay the person for interpreting the test. So there was money in this. And if you look at it, most of these are gels. But the thing that really changed it for me is I could actually earn money for the first time in my life in the mid-90s by taking all those clotting things, looking at them, reading the admission and discharge notes, and saying, I know what the patient has. And I wrote a paragraph about it. And a check came, right? It was a little check compared to signing out things, but I got paid, right? So that changed the picture a little bit. And then I realized we could build on all these things. So we don't make near as much as you would for doing anatomic path, but there was an income stream. And that made a difference because then we could start to build. I took the money that I had in Boston, and then I hired, for example, the one who could help me the most, of my clinical partner, Betsy Van Cott, who was a resident, took that money and hired Betsy, and suddenly we had 2 people to sign out coagulation studies, which meant we could do it all the time, right? How could one person do it? If you travel, if you're on vacation, you need to have experts across the board, as they do in anatomic pathology, to provide consistent service. So when you look at what clinicians order from the lab and what do they expect from us, it's not much. And let me just show you these data. This is from a paper in 2005, and this is the physician's rating of the most important service aspect. They want an accurate result. They want the stats as stats. They want routine tests and not too long turnaround time. They want us to be nice to them. But that's about it, right? Where's the advice? Where's this question in here is, figure out why my tests are abnormal, right? They have no idea how much you know. If I've looked at the people doing coagulation testing that I knew best through my career, 4 years at Penn, 19 years at the Mass General, and now at Vanderbilt, holy cow. I mean, what they could tell the clinicians at all the hospitals that that I work is immense. They know this much, literally, and I would say it's 100% more than what the clinicians know. And so they got to somehow realize that we know that and then ask us to do it. Well, we are not doing that well in terms of delivery of this health care across the United States. And we have a lot to do with regard to diagnostic testing services. So many people say we order too many tests. You know what we're really doing? We are ordering too many of the routine tests. These are the people that don't know and just order that CBC every day. What good is that, right? You know what the trouble is? That when you're 25 years old and you get a blood clot in your leg, most people have no idea what to do for a hypercoagulation. Should I check for heritability of a thrombotic risk? What is that? Factor V Leiden? Do I need the genetic test? What's activated protein C resistance? These are critical questions. And the fact is, they have no clue. So we've been in this vicious cycle for a long time. This is a society vicious cycle. You're trying to figure out 2x equals 4. You're in the 9th grade. Can't figure out how to solve for x because somebody just got shot outside your window. So you don't get smart then. You don't get a good job. You rob the grocery store, and it just goes on, right? So what happened in clinical laboratories, right? So in clinical laboratories now, here we are. We got a doctor up there who says, let's see, I got a 25-year-old person who just got a blood clot. I wonder what tests I should order for hypercoagulability. I know there are some that are inherited. They're going to be important here. And I don't even know how long to anticoagulate this patient with Coumadin. Gee, I wish I could get an answer to that. Who should I call? And in most places, it's not in a clinical laboratory. Who's going to answer that question? Remember the person who was working with DeBakey, she's now signing out cytopathology, right? So what happens is then there are no questions received by the laboratory on test use and interpretation. So the hospital says, what do we need you for, right? What do we need you for? If you're not going to do that, what do we need you for? So therefore, the clinicians say, well, I don't know, I guess I'll just guess. So then they guess about what test to order. And you know what? They order a factor V instead of a factor V Leiden. Those are two totally different things for those of you who deal with this. There are just so many mistakes that are made in ordering that even if you do the test perfectly, they can't get to a diagnosis. So there's less than optimal quality of care and increased cost to manage the patient. They stay 6.3 days instead of 5.8. And then the clinician said, gee, who do I call for this? And there it goes. So we have to break it, right? So how do we break the cycle? Now, this is one line out of a paper, look at this, that's now 10 years old. This is a great survey. Here's what they did. They said, you know what? There's so much information now being given to doctors that they have to deal with to sort this out. Let's do a survey and find out if they think they're in over their heads. Are they guessing about you? You know, we're all patients, too. Yeah, we're all in healthcare, but we're all patients, too. Is your doctor making a guess about you? Well, here's what they said. 7,000 surveys. They asked the primary care doctor, is your scope of care greater than it should be? Are you guessing about what you have to do? The fact is, 25% of these doctors said yes. For all us specialists, when I look and see a clotting patient, and I got some guy who's got 3 clots and his Coumadin's been mismanaged, and they don't know what to do with hypercoag profiles, we see the people sent to us from the primary care. They surveyed the specialists. 5,000 specialists said, oh, yeah, the primary care doctors have no chance. They have no chance. That was 10 years ago. You know how many mutations for the cystic fibrosis gene were 10 years ago? Probably about 10, 12. You know how many we've discovered now? 1,300. Some of them are associated with sinusitis, some with pancreatitis. This isn't just a lung disease anymore. Holy cow. 10 years, the amount of information is now huge. It was 25% 10 years ago by their own admission. So this is the healthcare world, and this relates to the laboratory big time.